Hello, everyone, and thank you for joining us for today's training, the fourth in our series on a transdisciplinary approach to behavioral health populations in primary care. My name is Rick Brown, and I am the Senior Director of Communications, Membership, and Special Initiatives with the Association of Clinicians for the Underserved. I'll be your host for today's training, and if you have any technical issues during today's webinar, please don't hesitate to reach out to me for help. On our next slide, you'll see that for those of us who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust, multifaceted workforce to help transform communities to advance access to quality care for all. We do that by providing advocacy, professional education, training and technical assistance, and more to develop and support clinicians and the broader healthcare workforce caring for America's underserved communities. We invite you to learn more about us and membership of ACU at clinicians.org. If you're interested in more resources in behavioral health for community health centers and other institutions working with medically underserved communities, we encourage you to visit our behavioral health program page, where you can find archived presentations, upcoming webinars and events, and more. And speaking of those upcoming events, on our next slide, you'll see that registration is now open for our upcoming 2026 Behavioral Health Leadership Forum, taking place on July 29th in Washington, D.C., following our 2026 conference. This full-day symposium will feature CE/CME accredited workshops, discussions, and much more on best practices in behavioral health for clinicians and leaders at CHCs. Applications will open very soon for scholarships offering free registration to the conference and forum for clinicians and leaders, so please stay tuned. And if you're interested in getting early notice, just DM me via the chat and I'd be happy to add you to our list as well. Also, before we begin, I just want to go over a few quick housekeeping items. First, we will be recording today's session, and we will share the recording and the slides with your team within a week of the webinar. We also encourage you to ask questions via the chat during the presentation as you think of them, and we'll have a dedicated Q&A at the end of the session. Also, please complete our evaluation at the conclusion of the training. It's tremendously helpful to help us continue to improve the quality of our educational events. Lastly, I am honored to introduce today's speakers. Dr. Virna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the Chief Operations Officer and co-founder of Zero Overdose, as well as a member of ACU's Advisory Council. She is a national expert in suicide prevention and collaborative care, a faculty member for Zero Suicide, and previously served for over 2 decades as the Senior VP for a large FQHC network in New York. Additionally, Dr. Jill Donelan brings 20 years of experience as a licensed psychologist in direct clinical care, program development and management, and implementation of evidence-based practices. She currently serves as the VP of Clinical Operations at Mira, a technology company specializing in behavioral health outcomes measurement, including measurement-based care and collaborative care management. She has successfully worked with myriad behavioral health and medical organizations to optimize treatment outcomes and to develop a culture of continuous improvement. We are honored to have both of these experts presenting with us today. And with that, I will turn it over to Dr. Little to kick us off.
Well, thank you so much. I'm really glad to be here. I'm very excited to talk all of you and to all of you and to continue this series. So please, as we go along, please feel free to put questions in the chat. I actually follow the chat as we go along. We can stop and answer them, or maybe I can address them, as I'm going through. We'll also leave some time at the end for some questions and discussion, so please feel free. So today, what are we going to talk about? We're going to think about some free-focused interventions. What does that look like as we're thinking about our behavioral health populations? We're going to think about some evidence-based practices that we can use for that population. We're going to talk about some CPT codes and how to be able to use them, and then also documentation that's going to be helpful for our clinicians, documentation that's going to make sense for our primary care providers, and is also going to meet some of the paying and coding requirements that we have to. So as we've been going along, for those of you who have been participating in the series, we've been working our way through this umbrella graphic. And one of the things that we've been doing is talking about each of the categories. So we spent some time talking about health-focused interventions, those health and behavior interventions, the smoking, the weight loss, those kinds of services that we provide in primary care for patients, and sometimes using the health and behavior codes. So one of the things that we're trying to do is to think about our entire population of patients that need behavioral health support and interventions in a primary care community behavioral health center population. And so we talked about health and behavior interventions, and then we talked about measurement-based care or collaborative care, particularly using the collaborative care codes, the dedicated CPT codes for collaborative care, but also talking about measurement and measurement-based care, because if we can measure it, we should. And there's quite a few behavioral health diagnoses that have validated tools to be able to look at outcomes. And then today we're going to spend some time talking about focused brief interventions. And a lot of times, what people will say is, "Well, isn't that kind of all we do as behavioral health providers in primary care?" The answer is no. However, really thinking about what are some of the services that fall outside of measurement-based care and fall outside of those health and behavior assessments. So what are we doing with some of the populations? And this also includes some services like groups or family counseling. They actually fall out. And so I want to try to ground us a little bit, because just because we're not able to measure doesn't mean we don't have a definition of success. And one of the things we want to do for every intervention, for every population that we're caring for, is we want to be able to define success, not only for the people that we care for, but for our teams and our clinicians as well. And so focus brief interventions, these are interventions that often can be individual sessions. This is where a lot of our groups fall. I love running groups in community health centers. I'm sitting in a community health center now. We were talking about it today a little bit. There is some limited opportunities for some billing and coding there, but oftentimes groups are very reimbursable and a really nice way to provide and expand access that you have for patients. Also, some evidence-based models. What are some of the very specific evidence-based models we can use? So focus brief interventions does not necessarily translate to length of treatment. We're more talking about the services that we're providing to populations. However, that doesn't mean that we should always be providing longer term treatment. One of the things that we talk about in community health centers and sort of thinking about, quality behavioral health services is clinical necessity. And oftentimes putting in a quality measure that says after 12 sessions or after 15 sessions, we're actually going to review that chart and we're going to look for clinical necessity. And oftentimes that's where we see some gaps in documentation and treatment, is that there may not be the clinical necessity there. And so, again, it doesn't necessarily translate to the length of treatment. It's more about who sort of falls into this bucket in your total population. And we want to really pay attention to clinical necessity and what kinds of evidence-based treatments we're providing. For these codes, for the most part, we are going to be using the psychotherapy codes. These are the psychotherapy codes, and oftentimes there's some confusion about the time frames for them. The most common psychotherapy code used in community health centers is the 90832, which is that individual therapy code, and that's a minimum of 16 minutes. That oftentimes we forget. We were talking a little bit about some warm handoffs today and the ability to meet that 16-minute threshold and how that might be documented. Oftentimes, the next most common one is that 45-minute psychotherapy code. I would say for the most part, organizations are not using 60-minute psychotherapy codes anymore, nor should they. A lot of payers are asking for prior authorization, so that's not a code that we really use in community health centers. I did include it here. Oftentimes, I think we forget about some of the family psychotherapy codes with the patient or without the patient, and then also our group codes. There are some additional codes like the 90839, which is a crisis code. We're actually going to talk about that a little bit more in our next webinar, but that would be sort of in this bucket. And these are the codes for which you're going to get your PPS rate. So there are some codes here that can be used for some initial assessments. So This 90791 is that initial assessment for a non-prescriber. So someone that is a nurse practitioner, a psychiatric MD, they would not use this code. They would use the 90792. This 90791 is that initial diagnostic evaluation. One of the things that often gets asked or is still out there is that, do I have to do a diagnostic assessment before I can get paid for any of the psychotherapy codes? The answer to that is no. That used to be the case. And then payers realized and patients realized and clinicians realized that that was not a great model. If you think about what the DSM says, it says actually it takes some time to do an assessment, right? You can't just really, it's not reasonable to expect that it happen in one session. It takes over time. And then also, it's not a very engaging process. If I come in, it's really about me as the clinician trying to get all of this information from you and check all my boxes and fill out the form. And so a lot of times what we were finding is people weren't coming back for those second sessions. And so you don't need to have it. It just needs to happen sort of in that initial process. You heard me mention very briefly these psychotherapy codes for crisis. They, I think, are underutilized in community health centers, and that's because a lot of times people say, well, it doesn't really matter. I get my PPS rate anyways. So I would encourage you to think about a couple of things. That is true for Medicaid, and Medicaid is not your only payer, but also you want the services that you provide and use codes that are reflective of those services. So if you see a lot of crisis patients and you just use the psychotherapy codes, then you're not telling the story of the services that you're provided. You're providing maybe the emergency room visits that you're preventing. And so you really want to make sure that you're accurately using the codes and coding for what you're actually doing. So a couple of things to really think about. We want to make sure that we're accurately reporting the time. These codes are time-based, and they are time that's based on the total time in that face-to-face treatment, that telehealth or in-person, regardless, it's the time spent in that actual face-to-face encounter. And so one of the things that we want to try to do is make sure that we're accurately reporting that. If your EMR doesn't have a time tracker or something to be able to do that, we're actually adding it at the end of each note. I was in a health center the other day and they were not noting their time. They were saying, well, it says 30 minutes on the schedule. Someone scheduled for a 30-minute visit. That wasn't enough to actually support the documentation of the amount of time that they were spending with someone. So you really want to make sure that you're accurately reporting that time to the minute and not using the same time each time. So because we're talking a lot about the psychotherapy codes today, I thought I would talk about some things that actually come up often in community health centers in particular. So one of the things that we want to make sure is that the documentation justifies the services, the diagnosis. Hello, Dr. Donelan. Welcome. We're gonna put you on the hot seat in a couple of minutes. So thank you for joining us. So we've been talking a lot, and a lot of questions have come in around some of the key medical necessity requirements. So we were looking today around what do you need to do in order to support the psychotherapy codes? So first, we talked about the time documentation, right? It has to be clearly documented in the record. It has to be a licensed provider or someone working under the direction appropriately for a licensed provider. So perhaps a student that's working under a licensed provider, and that's okay in your state or with your payer. The documentation. So there has to be a diagnosis. We have to have a treatment plan, and we have to have notes that are justifying, is it individual treatment? Is it family treatment? What does that look like? And they have to be for the treatment of a mental health disorder. So a lot of times I will see documentation that really doesn't support the clinical necessity. There isn't a mental health diagnosis, or we're not clearly providing treatment for that individual or family. So a couple of things that we often see in community health centers. One is over documentation. And not progress notes. And so remember, there's very specific guidelines around psychotherapy notes and progress notes. And one of the things I like to sort of talk about when you think about a progress note or a note for these services, it is what is the diagnosis? So, patient here for ongoing care of major depressive disorder. And then what symptoms got better? What got worse? That assessment of symptoms. So, if I think about the symptoms that would be attached to major depressive disorder, then am I feeling hopeless, right? What are some of those symptoms that have gotten better or gotten worse? And then what evidence-based practice did I provide? So if I use CBT, what cognition did I reframe, right? If I use motivational interviewing, then where is this individual? If I use behavioral activation, what goal did I set? So 2 or 3 sentences, what evidence-based practice and what was that specific skill? And then lastly, what was our progress towards the goal? A short-term goal, maybe a goal that we might set that I'm going to follow up on, and what is our long-term goal? And so that is a very specific note format that will often be really helpful. It's a note that primary care providers can follow easily. It keeps our behavioral health providers from writing longer notes, particularly if they might have come from other settings. And then we also want to really think about very specific evidence-based models. We're going to talk about some today. It is super important to adopt and use evidence-based models in your setting. We want to make sure that you're not including case management in the time. I looked at charts the other day. They were billing psychotherapy codes, and it was for all social determinant services. They were helping with concrete services, and those are not services that are included in the psychotherapy time. Treatment planning process. When you start to build psychotherapy codes, you have to have a treatment plan. You have to really look at it, track it, and not provide treatment outside of the planning. So you need to make sure you're updating that treatment plan every 90 days and you have a process for that. So you're not providing treatment outside of that treatment planning time frame. One of the things that I do is I update it every visit, and then I don't have to worry about it because I'm just put update plan with whatever my new short-term goal is, and then I can reinforce my long-term goal. And then I never have to worry about it because it's a living document that I'm just using all the time during care or treatment. And then the other common finding in community health centers is that, you know what, I'm not really seeing someone regularly. They just see me whenever they come in to see the primary care provider. And so you really have to think about how you're documenting that because someone is not in treatment, really. That's sort of a one-time intervention. So, what are you seeing them for? What diagnosis are they presenting with? What intervention are you providing? Are you maybe teaching some mindfulness because they're struggling with sleep? Are you doing a DBT skill, right? Whatever it happens to be. And then clearly documenting that this person is not engaging in care, that this was a one-time intervention, that they are not in your care or treatment. And so oftentimes you see that, and oftentimes people will do these ongoing notes as if someone is in treatment, but you really wanna think about that model. So this is a little bit of an overview of that documentation and sort of what it looks like, and avoiding terms like psychoeducation, supportive counseling. I actually got some legislation from Kentucky, I think it was, that took psychoeducation off of their billable codes, right? So I know, Jill, I see the face, but that's new legislation now, right? And so you really want to make sure, is that billable, is that included, and maybe think about using some of those terms. And so as we go forward, really talking about evidence-based practices, Jill, Dr. Donelan, I actually put you on the hot seat now because you're here. Uh, so one of the things that we're talking about are interventions that we can use in primary care settings. And oftentimes, one of the populations that comes up a lot are early childhood. So, what do I do for families? What do I do for, I'm going to call them the little ones, right? Sort of the preschool age, the early ones, your specialty. And so, I'm wondering if you could just take a moment and uh, talk for a minute about what some of the more prevalent diagnoses you see there, and what are some interventions, evidence-based interventions or resources that people could use for those populations? And I know I'm putting you on the spot, but you could
No
talk
worries.
about this all day.
So in terms of presentations in this age group, I guess I want to just start by acknowledging that diagnosis in this age group is probably a little more tricky than it is in other age groups, because we have the overlap of sort of environment and parenting and caregiving with social environment and social needs, which have a huge impact on early childhood. And then we also have development, which is rapidly, in those first 5 years, is progressing very rapidly. And so kids in this age group can present with traditional types of behavioral health presentations, disruptive behaviors like you might see in older children, sometimes even pretty clear anxiety, things like separation anxiety, sleep or dark, like exaggerated fears of the dark, things like that. But we'll also see it come up in other ways. So, delayed developmental milestones is another thing that we often see. Obviously, that can have many root causes, including developmental concerns. So, this is part of where we have to kind of tease things out. But the other place that we see this come up is relational concerns. So, youth in their first several years of life really rely on their primary caregivers to survive. We all know this, of course. And so, it is often in the context of that relationship that the symptoms emerge. And so, oftentimes, the parent is the one who's really expressing the distress because the child's behaviors or development are not meeting expectations, or sometimes there's just simply a not great fit between the child and the caregiver. So, again, there's a lot of opportunities to sort of identify kids in this age group. We can definitely map these two behavioral health diagnoses. And I often hear from folks who aren't as familiar with their little guys that you can't give a behavioral health diagnosis to a kid under fill in the blank, 5, 3, whatever. That is not true. There is an entire diagnostic system for this. And you don't need to know all of that, but you can definitely diagnose behavioral health concerns in younger kids. And it often looks like things like those disruptive behavior disorders, mood dysregulation, and other sort of concrete developmental concerns are some of the things that often end up in the diagnostic categories. In terms of treatment, I talked about that caregiving environment. Um, I am a pretty firm believer that there is no treatment of kids under 5 or 6 without pretty intensive caregiver involvement. Certainly, kids can benefit from some positive time with a therapist, but it's not going to really stick in any significant way when it happens a half an hour or an hour here and there. The caregivers spend 24/7 or close to it with their with their kiddos, and so they really do need to be involved in not just the assessment and identification of behavioral health concerns, but also those interventions. So a lot of the interventions look like skill building for the caregiver so that the caregiver can help the child build skills. So it's kind of like a kind of a little bit of a circle there. You have to kind of follow that lead. But kids don't develop skills at this age in isolation. They don't do worksheets. They don't do homework. There is no such thing, right? So what we need to do is help caregivers find and use those real life opportunities to help the child build skills like frustration tolerance. So can we help them to accept change in their schedule? Can we help them to learn to wait their turn just a tiny bit more regulated? Can we help them when they're feeling scared to label that feeling and to be able to co-regulate, is the term that we talk about when parents use their own sort of regulation to help regulate the child. So there's different ways that you can approach this. Some of the interventions that are evidence-based are more skills-based and more directive. So they're kind of like parenting interventions, ways that you can add schedules and behavior reinforcement for kiddos who have disruptive behaviors. And some of them are a little bit more process and relationship based. And so it's helping that parent build those co-regulation skills and that sort of thing. But again, you'll kind of notice that caregiver is a very strong thread throughout all of them.
hmm So if I'm a behavioral health leader in a community health center and I really want to start to think about caring for this population, right? What are some resources or guidance that I could give my primary care providers to say, here's when it might be good to make a referral, and then what training tools would I give my behavioral health providers who absolutely were not trained likely to work with this population? What would I do for them?
Yeah, so I would say in terms of the PCPs, especially with this age group, the approach that works best is the no wrong door approach. So you certainly universal screening is great, and anytime that can be implemented, all the better. But that's not the only way that we find kids. One of my favorite studies in this area basically sort of compared lots of different ways of screening early childhood for behavioral health and social emotional problems. And they found that asking parents one question, do you have concerns about your child's uh, development or I'm trying to remember the exact wording of it, but it's like their development or their well-being. And if the parent says yes, that is just as effective as the fanciest screening tool you can come up with for this age group. Caregivers know when there's a concern, and we should trust and listen to that. Doesn't mean they're always going to know what the concern is or how where it fits in terms of service lines. That's sort of a separate level, but we need to accept when parents recognize and are asking for help, we need to make sure we give them that opportunity. Ask them if they have those types of concerns. And if they do, letting them know that services and resources are available. The
I love
universal
that. I
screening
feel
is
like
great.
that's the gem for the day, that question. Yeah.
Yep.
Mhm.
So lots of different ways, but no wrong door is sort of the mantra here, because kids will present. I talked about that at the very beginning in a lot of different ways. And if a child is presenting in these ways, and the parent has concerns or caregiver, I say parent a lot, I mean any of those primary caregivers, they can be a lot of different folks, but that's a good clear signal that this kiddo might need some more services, and at least some further evaluation is warranted. In terms of training for care managers and the clinicians doing the work, I know not everybody has had training in this area. There are some great resources out there. There are lots of evidence-based models available. Healthy Steps is one that many pediatric offices and medical systems have already subscribed to. So it provides like a nice structure for talking to families about child development and wellness and those social emotional skills, and offers sort of tiered interventions for when a child is struggling, like what can we do to sort of help them with that next step. Um, there are other models out there as well. In terms of identification and assessment, I would recommend, if you're wanting to really get get immersed in this, the DC 0 to 5 is the diagnostic system for young children, and they offer a training course that is way more than diagnosis. It's really how do we formulate and think about wellness across all of these different dimensions in young children. And it's a really great foundation for then thinking about how do we intervene. So that's probably my top sort of training recommendation. But there are, again, lots of other resources out there as well. That
Awesome. Thank you. Any tips that you can think of for those behavioral health, um, leaders to be able to identify these populations? So you mentioned universal screening. Are you thinking about MCHATs? I actually saw something the other day that the MCHAT, there was some question about accuracy, like literally just saw the article the other day, but I'm not really sure what alternatives there are. But when you're thinking about universal screening, what are you thinking about?
Yeah, so universal screening for this age group often looks like developmental screening. So it's asking about developmental milestones that span language, cognitive abilities, and social emotional functioning. And so again, those are non-specific, right? Like it could be that the child has a cognitive delay or developmental delay, or autism, like you're pointing out. But it's a great place to start because it's accessible and because many pediatric offices are already doing it at some cadence. There are specific screeners that are more focused on the social emotional well-being. The two I would point to for this age group is the Baby Pediatric Symptom Checklist, BPSC, or the Preschool Pediatric Symptom Checklist, PPSC. Those are two validated measures. They're completed by the caregiver. They're both like 30 questions long, so a little bit longish, but ask a lot of questions about that social emotional functioning and give you the ability to sort of understand, is this child exhibiting more concerns in this area than would be typical for their age, which is really what we're trying to look at when we're kind of quantifying it.
And so if you're thinking about universal screening, you're going from those tools into the pediatric symptom checklist as they get into the early school age.
Yeah, I mean, I think ideally we would be screening kids for social emotional problems in a more standardized way. I think the reality is most practices don't have that bandwidth or capacity. And so often it is more general screening. It's the observations the PCPs are doing, it's those caregiver concerns. I will tell you, even though little guys are not in school by, age 3 or 4 necessarily, or many of them are not, the school-like environments, daycare, and early preschool type settings are often the places where these symptoms are also coming up. So, PCPs are listening for feedback about how things are going in those environments where children are either excelling or maybe where they're struggling with their peers and their sort of other adults in their life. Those are all sort of places where we can be looking to identify kids who have social emotional needs.
Perfect. Thank you. I want to just give one moment in case someone has a specific question for
Yeah,
you. I just had folks put in the chat, and I may need to circle back with you later if there's
yeah.
some that come up later. But I greatly appreciate your expertise, and I know in many primary care practices, as we think about sort of this population, they really fall off the radar when we think about our behavioral health populations. We don't even think to include them in sort of that population. And so sort of that ongoing screening, that identification,
Yeah.
and then what do we do, right? Yeah. And
I will
so,
tell you, one of the reasons I got into this was because I had so many parents working with older children, so many parents who would say kind of jokingly, well, just give it a couple years, you'll be working with this one next. Right. And they'd point to the younger child, right? They'd be sort of indicating that they could already see, even though the child was too young for services,
mhm,
that younger kiddo had some needs. And to me, that's just like, why are we waiting? Why are we letting
why are
this
we waiting?
fester
Yeah.
and continue to get worse when there are things we can do? And so that's really part of what motivated me to want to do
Right.
this work because we can see it. It is there.
hmm Well, thank you. I really
Yeah.
appreciate your time and your expertise. And there certainly is no one who knows more about these things than you. So thank you. I always appreciate it. And we really appreciate you taking time out of your busy day to drop in on us.
Not at all. Do you want me to stick around or you?
No, that's up to you. You are entirely
Okay.
up to do
I'll stick
whatever
around for
you
a
would
few
like.
minutes and then
Perfect.
definitely if there's questions, I will say we're trying to pull together more guidance for this exact reason and putting it out in a way that makes it more accessible. It's a work in progress. So Verna will be the first to know when it's available, and I'm sure she will help us disseminate that widely.
Absolutely. So thank you. And I appreciate the time that you spent sort of talking about evidence-based practices. I really think it's helpful to adopt some very specific evidence-based practices or models, and not that it's, a one size fits all or it's the answer to every question. But what it does is it really does give some structure to your treatment. It's really helpful for clinicians. It also is really helpful for providers who then understand, oh, I know what this model is. I've been shown this model. I get the treatment. I know a little bit about it. They can do a better job sort of talking to their patients prior to referral, or if they think people might need support. And so it sort of becomes a way to really help you manage your behavioral health populations. It also gives you some structure in terms of how to define success and how to determine a length of treatment. And so really encourage you to start to think about what evidence-based practice models you have that you've really sort of implementing and follow. So we put a couple up here that we thought might be helpful for some of you to start to think about for this particular population. I put 4 R's and 2 S's here. It was one of my favorite models to do in community health centers. And we initially did it as a multifamily group, which is sort of how it was designed. And it was the favorite group for my clinicians to run. They loved running this group, and families loved coming to this group. We ran this group in many community health centers across New York for more than 10 years, and it was running successfully. People loved it, and it actually is still continuing. And that multifamily component of it, it's a 16-week curriculum. It has been adopted to work with individual kids and families. I still like the multifamily way better, but the manual is available online, and I'm more than happy to share the manual and some of the worksheets. This was really helpful because a lot of times we would get referrals from pediatric providers, and they say that, like, there's some problems, right? There's some behavior. It hasn't sort of come to the point, of a diagnosis or even where something major has happened, but like we're having some difficulty. The family is struggling. This was the perfect group for those families. And so it really gave us a way to be able to care for some of those patients. And so we can give you the group manual. There's a reference guide, there's some brochures, there's a facilitator handbook. Rick will actually share these slides, and I put the links here to all of these materials so that you could have them and get them if you need. And they're wonderful materials. It's actually, again, something really helpful, and it helps you care for a whole population of patients in a very structured way. And it also helps you to manage the volume in primary care, because one of the things I always struggled with as a leader in, primary care was I just managing the volume, like just the numbers of referrals. So how do I give the right care to the right people? So this was an incredibly helpful way to do that. Also, sharing the Seattle Children's has particularly, Jill is laughing, right, with the
I'm
fast
laughing
training.
because I just put that in the comment that I forgot to mention
Oh,
it.
did you? Yes. So, Seattle Children's, particularly in the last couple of years, has done a phenomenal job building out these fast trainings. And I don't think a lot of people know about them. I don't think a lot of clinicians know about them. They are trainings there for parents. There's trainings for providers so that the behavioral health teams could go. You could send families there and give them links for particular trainings. There's multiple ones. There's workbooks, there's videos, and it is incredibly helpful. And again, if you have behavioral health providers that weren't trained to work in this population, these are incredible trainings. This is a way to get parents involved. And again, it's a very specific model that you can share with your primary care providers. Hey, we're doing this now in behavioral health. Here's information you can give to people when you make that referral. So super helpful. And again, very structured, very specific, very clear kinds of training. So I don't know, Jill, if you wanted to add your experience of FAST or some of the different areas, what your experience have been or how you've seen people use them.
Yeah, I mean, the early childhood one is newer. The anxiety, behavior, trauma ones have been around a little bit longer. So there's a little more evidence, but they're all really structured and built around those modules and those sort of skill-based interventions. So I really like that you can use parts of it and still, ideally you're using sort of the whole module, but when you can't, because that's real life, you can still have some really effective interventions. It's all based on what we know from evidence-based interventions for kids. So I think it's a really great packaging of what we know works.
So here is actually links to some of the workbooks and some of the resources and things that are there. I encourage you to actually go on the website. You can certainly download these. You can use them in sessions. They are incredibly helpful, very accessible, very targeted off, audience, and again, sort of very evidence-based. So really encourage you to think about some of that. Um, if you remember from our umbrella diagram, we put addiction and suicide across all of our categories. One of the resources that's incredibly helpful is Now Matters Now. And I put this up here because there is free training now for providers on this website. There is also resources and training for individuals that are struggling with suicide risk. There is DBT training that is there, cutting personality. And so the ability to really build out DBT in your practice and use DBT as an evidence-based practice for multiple populations is really helpful. Oftentimes, I will pull Now Matters Now up when I'm with someone and actually go through it and talk about some of the interventions that are on there. There's a wonderful skills library. And again, people can participate in the group. So it's something that they could do in between care and treatment, or that you could give people as a resource. So really trying to share some of these things that you can build into your practice to augment. And there are some really wonderful, wonderful videos there. Oftentimes, people will ask about CBT. I often see CBT documented. I did CBT or use CBT. And it's really helpful to be very clear in your documentation about what CBT skill that you might be using. And so, really thinking about what that looks like and trying to do some really clear training for your providers and including it again. So, Jill, I don't know if you have other CBT resources. We have some here that are incredibly helpful to be able to talk about. One of the ones is there's some really nice on the Beck Institute things that you can pull into primary care, but not sure if you have some other resources or things that you want to share.
There's so many out there. I would emphasize even here and even with slightly older kids, a lot of this is really effective when the parents are also learning the skill because they're the one who can help the child practice and reinforce it in other settings. So that is my little tidbit of advice is don't leave out the caregiver even when we're talking about sort of school age kids.
Mm-hmm. So when you think about some evidence-based modules or interventions. We're going to talk about some now for some more acute. I really think it's helpful to pull out some of these core skills, actually list them, and then be able to share them with the primary care providers so that they can talk about them when they're making some of the referrals. So I think that's pretty helpful information. So I wanted to make sure that we left about 10 minutes for some questions and answers. We usually get quite a few questions and answers, and a lot of times I get them afterwards. So I encourage people ask them now so that everybody can hear the question and the answer so that we can try to do that. So I'm going to start pulling them up now. And please send them to everybody and then not just to me. Oh, here's one. So this one actually you could probably take, Jill. So when you think about early childhood, what's the earliest age of children you treat in primary care?
So I'm gonna be a little controversial here and say that I'm not sure there is a minimum age. And it also depends on your model and your billing structure. So take away billing and CPT codes, and I would say that we know even prenatally that certain babies are at higher risk, and based on sort of parental mental health needs and systemic factors and trauma exposure, things like that. So there is maybe no lower limit in my mind, caveated with, of course, you have to find a way to actually deliver that service that is in line with all of your billing codes. So that makes it a little more challenging. And I will point to some really great research that's been done in this that sort of went all the way down to birth and showed some great outcomes. So this has been done. I would say in practice, it's usually in that toddler age, 2 to 3, when we tend to see the caregivers really starting to speak up about the need for those interventions. So could we go further upstream? Yes. Do we usually? Maybe not as much as we should, but
If we were going to add the coding and billing back into that, what codes do you find yourself using more often for those visits or interventions?
I think a lot of where the future would be if I got to create it myself would be the ability to diagnose and treat dyadic concerns and to treat those early exposures and those early risk factors before they turn into a disorder
Mhm.
in a preventive way. We don't really have a lot of great mechanisms to address prevention in this way, but we have really good models that tell us which kids are at the highest risk.
Mhm.
And so if we could identify those kids and treat them early and provide that prevention through their caregivers, I think we could head some things off at the pass. And if we could really embrace this relational aspect of early childhood and the ability to diagnose those relational concerns and treat them as such, I think we would make additional progress in sort of children's well-being.
Mhm. What codes do you find yourself using most often? Like what CPT codes do you find yourself using most often?
I'm not sure I'm the best person to answer that because I'm coming at it from a pretty specific lens of most of the folks that I'm working with are doing collaborative care, so they're using the collaborative care codes
Hmm.
pretty much exclusively.
Okay.
But there definitely are other codes that can be used, and there are states that are pushing the boundary on this and giving us broader options. So I'm most familiar with Massachusetts because it's an area where I've practiced where any youth up to age 22 can now get up to 6 preventative behavioral health visits using more
Hmm.
traditional outpatient therapy codes without a diagnosis.
Hmm.
And so it really gives us a window to be able to do some prevention in a different way. And there are other states that are, have enacted different kinds of legislation to address these same needs. So it's not to say that nobody's doing it yet, but it's not universal. It's not sort of routinely accessible.
Hmm. Great, thank you. Um, yeah, and so there's a comment in here, 99401 and 99402 for healthy steps. So thank you for putting that in there. Yes, very common code. Another question in here about my comment around patients that are just coming in to see, and we're seeing them in behavioral health when they're seeing their primary care provider. So, yes, there is some liability there if someone doesn't have a diagnosis, right? And there isn't clinical necessity to see them. And if you're not documenting as a one and done, it isn't one ongoing treatment episode where you might be seeing someone 3 or 4 times a year. Those are individual treatment events. And so you want to document it in that way. So yeah, I definitely would want you to think about that and maybe try to address that if that's happening in your setting, and maybe talk to your, compliance folks and look at some of the codes and look at some of the diagnoses. Um, so great. Just give another minute, make sure we've answered everyone's questions. Okay, Rick, I'm going to turn it back over to you for any upcoming and future um, announcements.
Absolutely. Thank you, Verna. So we're excited to see you at the final webinar in our series. The next one will cover a deep dive into complex mental health needs, capping off our 5-part webinar series. You can also review, if you've missed one of our previous presentations, recordings and slides from each of our webinars on our website. The other thing that I might mention again as we close out as well is that we will be hosting our 2026 Behavioral Health Leadership Forum, and scholarships, as I mentioned before, will open soon. So if you would like early notice prior to our public announcement, please just let me know, and I would be happy to share our registration form with you prior to that. In the meantime, I hope you'll stay tuned for our next presentation, and thank you so much for joining us today.
Thank you, everyone. Have a wonderful day. And thank you, Dr. Donelan, for dropping by.
Thank you. Have
Thank
a
you.
great day.
Bye-bye.
Bye, everyone.